Welcome back to the Dermcast studio. It's Rob Casquejo, and we have a very special guest today, hailing from Boston by way of New Jersey. It's Dr. Gabriela Cobos. Welcome. How are you, Dr. Cobos?
Hi, Rob. Thank you so much. Thank you for having me today.
Well, we're so happy you're here, and thank you for supporting the SDPA. And let's start by introduce yourself a little bit. Tell us about your academia, your background a little bit as a physician.
So I did my medical school at the University of Pennsylvania, which I love my time in Philadelphia. Then I ventured back closer to home to New York, and I did my residency at NYU. And then I did a dermatology, rheumatology fellowship at the Brigham, and then loved it so much that I decided to stay there as an attending, and that's where I've been for the last couple of years. My specialty clinics at the Brigham is psoriasis, connective tissue disease, and bullous disorders.
Well, that's awesome. That's great. So your backdrop, you have expertise in the disease states that can be very confounding at the clinical level. So let's focus on bullous disease. This is something that all of us have seen in clinic, and it can be, the presentations can overlap. There's a lot of tricky diagnostics involved, and therapeutics can be difficult. So tell me about your mile-high view of an approach to a bullous dermatosis.
Perfect. So I think I'm in the lucky spot that as a referral center, I kind of get sent the diagnosis already. So I think that's an advantage for me. So I think it's always easy to play kind of like the Monday night quarterback and say, this should have been done, or this was missed.
So the H&E is done, the DIF is done?
For the most part, right? If someone comes in and it's a brand new patient that doesn't have a diagnosis, but there's suspicion for a bullous disorder, one thing that I always want to make sure we do is get the H&E, DIF, a salt split if I'm confused in certain ways, to make sure that we're able to get the patient the right diagnosis. If a patient comes in and let's say a DIF has not been done, that is something that I will always do, even if the exam looks pretty classic for a bullous disorder. But like you said, we are putting these patients on quite heavy medications. So for me, I always think, how would I treat a family member? I would want to make sure 100% we are in the right diagnosis before we kind of go on this journey with all of these immunosuppressive medications.
Right, and there it is. It always comes down to, you'll have to probably involve some therapeutics that are heavy hitter medications, what I like to call baggage medications, because they always come with things you have to worry about. So once you have your diagnosis, and there's going to be different therapies for different diagnoses, but they have similar risks. So what is your approach? What should we worry about as clinicians when we start to use and think about using these medications?
Sure. So particularly if we look at the pemphigus population, they tend to skew a little bit younger. And so for most of these patients coming in, we're a little bit lucky in the sense that they're overall pretty healthy patients who are now kind of dealing with this brand new rare disease. So I think that's a little bit of an easier group to go through medications with. When we think about our pemphigoid patients, right, and we see that obviously a little bit more commonly, that pemphigus, they tend to be much older. So we're talking 60 plus, usually more in the 70s, 80s, a lot of comorbid conditions. And so when I'm thinking about medications, right, usually my first line is we do need prednisone. It is the one thing that works quickly. And patients are very uncomfortable when they're covered in either blisters or they're having denuded skin. It's painful. But beyond prednisone, right, and I always counsel patients, and I tell them, listen, this is the one drug that works really quickly, but I heard this rheumatologist once say P is for poison, for prednisone, right? There are so many myriad of side effects that if we're keeping these patients on for quite some time, we really can cause some damage for them. So I always tell them this is going to be kind of like our acute burst. We gain control while we have other things cooking to be our maintenance therapy.
And I'm so glad you brought that up, because it's probably the number one hang up when we treat these diseases is you give the prednisone, it works, and then you're in this no man's land, right, of waiting for a therapy, an immunosuppressive to kick in. And the thing that's probably most difficult, probably one of the more difficult things, is the patient is asking you, why can't I stay on the prednisone? So let me ask a specific question then in terms of prednisone therapy. Where in the initial stages, after that first burst, that acute burst, and you've tapered them and you're going into your immunosuppressive therapy, how soon will you go back to prednisone or do you do it at all? Yeah.
And so usually for kind of my prednisone burst, I'm tapering them over 6 weeks or so, right?
So a long taper.
It's a long taper. And for me, I always say, listen, I'd rather kind of do it this slowly initially so that I don't have to kind of come back and have to keep hitting you with these doses of prednisone. On day one, I will start the prednisone, but I'm also starting the steroid sparing agent. And so we're having the conversation about this is going to be the maintenance thing, but most of these medications take 8 to 12 weeks until we see the results of it, which is why we need the prednisone to get you more comfortable. I think the other part of it is if a patient comes in and they have a little bit more limited disease or they're not that uncomfortable, there is room to say, okay, do we really need the prednisone to gain control or not? Or is the patient okay dealing with topicals, a little bit of discomfort, and letting the maintenance therapy kind of kick in?
Great. And so then in the long phase, the long game of the immunosuppressive, they're doing okay, they break through. How quick are you to reach for prednisone? When do you do it? Do you prefer not to do it?
So my preference is always not to do it, right? But I think if a patient's kind of overall pretty well controlled and they have a minor flare, I'm not doing 6 weeks again. It would be like a pretty short burst of medication, maybe 10, 12 days. But if I'm seeing that even though that they're on this maintenance therapy, they're having kind of these flares a little bit more frequently, we talk about either changing their maintenance therapy or adding other medications to try to gain better control so we're avoiding kind of these frequent prednisone bursts.
Got it. And just quickly, in terms of your long burst, your long stretch of steroid, are you starting at 1 milligram per kilogram? Do you sort of hit it really heavy at the beginning? What's your preference?
So for pemphigus again, a little bit easier, yes. I think 1 milligram per kilogram, and then I taper kind of. Initially, I always tell them, I'm like, you and I are going to become best friends. We see each other pretty frequently because I want to make sure I'm seeing how you're doing on therapy, that we're monitoring everything. Once you're a little bit of control, then we space out your visits. For the bullous pemphigoid patients, right, it's anywhere between 0.5 to 1 milligram per kilogram. And again, these are frailer, older patients. They have really bad diabetes. They have congestive heart failure. I've had a patient that's ended up in the emergency room twice with a congestive heart failure overload, not because of our medications, but just on her own. So that's the patient I'm like, when I gave her prednisone, I kept counseling her on kind of, these are symptoms that you might feel if it pushes you into like a CHF exacerbation. So for patients that are a little bit older and more comorbidities, I try to stick to the lowest amount of prednisone that I can.
Great. And again, the trap is that it works good because it's such a broad-reaching medication in terms of immunosuppression. So now your backdrop, you did this derm room fellowship, which is fantastic because this is, you know, some of the most difficult diagnoses we see are based in connective tissue disorders. So can you tell me a mile-high approach to something that you believe is a connective tissue-driven dermatosis?
Perfect. So I mean, I think for one of the lectures that we gave today, kind of walking through a potpourri of complex medical dermatology, I think one of the big takeaways, a very savvy question that was asked was, when do we involve rheumatology? And I think for me being in an academic center, it's an easy way to always communicate with our rheumatology colleagues to make sure that together we can give the best care for the patient. So I would encourage for other providers that are more of like in a private setting, if these kind of connective tissue things, like you've said, Rob, they're rare, right? You really want kind of expert management of these diseases. So that's where I really would encourage folks to kind of reach out to have a rheumatologist that they work closely with, pulmonology if it's needed, but just to make sure that everyone's expertise is kind of providing the best quality care for the patient.
And because the diagnoses can involve so much systemic disease, and you know, some of the incidences of, for instance, systemic lupus with something like discoid lupus, not necessarily high, but the possibilities are there. So would it be safe to say you prefer to involve rheumatology early and often?
So for me, and I think because I've done this training, and I think even in NYU when I was a resident, I actually saw this quite a good amount. But because they're so rare, that's the reason why I wanted to do the extra year of training, was because there's little nuances and intricacies from each diagnosis. So like I said in the lecture, for me, I'm very comfortable managing if it's a skin predominant, let's say a systemic lupus patient, but it's skin predominant is the issue, I will be quarterback, but I will always collaborate with our other colleagues, right? In difference in like if a patient has mostly joint, lung disease for their lupus, a little bit of skin, I always try to make sure that I'm working with the rheumatologists who optimize everything we can from a skin perspective so that their therapy is directed at what's driving the patient's disease mostly.
Okay, so last question, always gets asked in these kinds of settings and lectures, drawing labs in perspective of a connective tissue disease. Do you always do it in your workup, and what is your tendencies in terms of what you order?
Sure. So, I mean, I think this is actually a great question, so thank you for asking that. So, I mean, I think the main lab that we're hinting at is that ANA, right? And so for me, when I see a patient and they have frank cutaneous lupus, which for me, I don't need a biopsy, I'm pretty good at telling just from clinical diagnosis, but if you have biopsy proven, then yes, that patient deserves a workup to work them up for, do they have any evidence of systemic lupus? And then an ANA is indicated. But I think for me, as kind of more of a referral specialist, when patients are sent with, I have lupus, I have this rash on my face, and an ANA was drawn, and let's say the ANA is 1/240. For me, that's nothing, right? It is not a significant ANA, and then if we're looking at their clinical exam, it's rosacea, right? And so I think for me, labs are necessary if you are being driven by a clinical diagnosis, by what you're seeing, by review of systems. But one of my pet peeves is just drawing an ANA, let's say when a patient has hair loss.
Right.
No, because then the patient and the provider gets stuck in a place, what do we do with this positive ANA, right? There are
very ambiguous, not sure where to go. You almost feel like now you have to work
and now you have
something.
to, right? And like if the patient's like, well, overall I feel well, we know that 5% of patients of healthy controls will have a positive ANA at like a titer of 1/160, right? And so if we start drawing ANAs on everyone, I think we will be surprised. So I think your lab and your workup should be driven by your clinical expertise and your clinical diagnosis.
Fantastic. Well, that's great. You know, you validated a lot of things that I had been trained to how to think. So I feel really good coming from your level of expertise. That's great. Well, thanks so much for coming to Dermcast and for supporting SDPA. And I got to make it out to Boston. We got to go to a ball game.
Yeah.
I've never been to Fenway.
Listen, it's a hard day for Boston. Celtics lost last night.
Yeah, it's brutal. Yeah, I know. It's tough. It was tough.
But come to Boston. It's a lovely city. We'd be happy to have you.
Great town, great town. I'll look you up next time.
There we go, Rob.
Right. Thanks again for watching Dermcast TV with Dr. Cobos. It's Rob Casquejo.